Ladies and gentlemen, good afternoon. The webinar is beginning. Welcome. My name is Chris Wilson. I'm the Communications Director here at the Dallas-Fort Worth Hospital Council. Normally, our President CEO, Steve Love, would be here, but he was called away to a meeting today and he sends his apologies. Thank you for being here for this educational webinar hosted in coordination with Hall Redner, an associate member and longtime friend of the Council. Today's topic is AI governance, applying the NIST standard to health system structures. We have been looking forward to this presentation. Our speaker today is a national expert from Hall Redner, attorney and advisor Michael T. Batt. Michael works with hospitals to establish a robust data management practices, and he implements artificial intelligence, otherwise known as AI, governance processes. He assists healthcare leaders in making informed decisions about the ever-evolving use of AI, focusing on technology and the workforce that interacts with it. You know, this is a real hot topic in healthcare today, and we're really glad he's here, and we have a nice turnout as well. A final note, should you have questions, please feel free to type them into the question box or the chat box, and we'll answer those before the end of the event. And with that, ladies and gentlemen, here's Michael Batt.
Thank you, Chris. So here we are today. We're going to talk about artificial intelligence. That's me. Actually, that's a younger me. But here, let's talk about artificial intelligence, right? Artificial intelligence and AI governance specifically is the process of making informed decisions about this new type of system, right? This is a new type of system that's comprised of technology and humans. And we're going to dive a little bit deeper in that to understand exactly what that means for healthcare organizations. Specifically, as we think about artificial intelligence in our health systems, it's really tempting to focus on this new shiny toy, this new technology, and its ability to think like a human. And all these technology associated issues like privacy and security. There's also, is the technology going to provide accurate results? And will we understand how it works? But that approach of focusing on the technology misses part of the system. The analysis also has to include consideration for the humans. We must look at, study, and understand and control for how humans will interact with this technology, how they'll authorize that technology, how they may take action at the direction of that technology. And for that reason, AI governance is more than simply an extension of data governance or technology review process or expansion of the Office of the Chief Information Officer. It requires a broad and diverse group of stakeholders to come together to understand the technology, understand what it means to our healthcare organizations, figure out what the risks are, control for the risks, and really reshape our relationship to this technology. So that's my thesis statement. That's where we're going to go today. So how are we going to get there? First, we're going to, at a high level, talk about what AI is. You likely know, but I want to, because we're going to be talking about how do we bring people together to make informed decisions, we need to start with a foundation of what is AI. A little bit of why do we care, right? What is the underpinnings of regulatory guidance that's driving our need for AI governance? And we're going to move into what is AI governance, kind of defining the structures that make sense. A large portion of AI governance is focused on risk mitigation, risk identification. So we're going to walk through those. And some of those risks are understanding bias. Some of those risks are associated with litigation and what's going to happen. Data privacy, if it plugs into the wall in healthcare and it's got data in it, data privacy is always a consideration. And finally, we're going to wrap up the conversation, hopefully with contracting for AI, some provisions that we can get into contracts to really address some of these risks. Now, that's what we're going to try to cover in 4 to 5 minutes. So I hope your pencils are sharp and let's get into it. All right, so what is artificial intelligence? Artificial intelligence generally refers to a computer technology with the ability to simulate human intelligence. AI is a category of software. It's not a thing, not a device. It's a category of software. And it thinks in probabilities. And this is unique in the world of software to think in probabilities. We're going to dive into that with an example in just a minute. And that idea of how it thinks becomes our biggest challenge in orienting ourselves to this new technology because it feels like what we've done before, but it is very different. And let me give you this example. I'm a parent. I got a 5-year-old. So flashcards are a way we learn, right? And if my 5-year-old sees a flashcard that says 1 + 1 and he picks up a calculator and he types it in, he is always, always going to get 2. That is basic computing. 1 + 1 = 2. We could do it in binary, but we speak English, so I've got it this way. Now, if we take that same question and introduce it to AI, and we train it on the backside of those flashcards, the side that I get to see, 1 + 1 will show me 2 because that's the characters on the back of the card. However, if we train AI on the front side of the card, the side that my 5-year-old sees, when we ask AI what follows 1 + 1 equals, remember AI is just predicting an outcome. AI may return underscore, or AI may return question mark, because the training data that we provided to it was 1 + 1 = underscore, or 1 + 1 = question mark, or however those flashcards present. But remember, AI is just predicting the next thing, right? The next character, the next pixel, the next word. That is what AI is really, really good at, and it does it in this incredibly complex manner. So with that basic understanding of AI works, let's talk briefly about the underlying technology. AI is a large class artificial intelligence, also sometimes referred to as machine learning. There's nuanced details there. We'll skip that. Then what has really happened over the last few years, right, because AI has been used by healthcare for the last decade, is we've developed generative AI. And generative AI is this new kind of output from AI, where instead of sorting between two classes, what generative AI does is it predicts the next pixel, the next letter, the next word, such that it can, for instance, listen to a room and start to predict what the physician's note would look like. That's an incredibly powerful tool in healthcare, but also comes with lots of the risks. And that's the kind of tool that we're talking about here. It has a process of learning, and that's called training, right? So when we take an AI model and we start feeding information into it, we're training it. Training is the use of a known data to create the ability for the machine to generate predicted outcomes, help us arrive at that endpoint. But it's not always right. And when it's not right, those errors, those are called hallucinations. So generally, when you give a prompt to AI, the model uses its statistical ability to predict what the right response is. And that result, again, can be language, images, or video. All right. So picture pages is always fun, and pictures help us think and understand. And in this slide, what I want you to do is kind of visualize what we're talking about as we move through our discussion of risk. So up in the top left corner, you'll see the first step as we build an AI tool is to develop the data acquisition protocol. And what this is this is when we start saying, these are the relevant pieces of information that we want the AI model to digest to make its predictive model, right? We are going to give it this relevant information, and we're going to shape its outputs so that that relevant information is how it predicts the answer. Once we've compiled that information, and we're going to talk more about that, how we compile that information, we talk about bias, but as we compile that information, we feed it in, that's called the training data, we feed it in to the model and start training the model. When the model starts to create correct predictions, then we move through the model validation process. At some point, we're confident enough that that model is working that we can drop it down into the blue space, right? That blue space being where we've deployed it, productive use, you may consider. In that space, we'll have a new prompt, a new input that comes into the model. Maybe it's an audio file, maybe we type some words. Then the AI tool crunches on that input that we've given, and it predicts that output. If that output is correct, we may take it as it is. We may modify, right? I could on the prompt side, I can say, write sweet Valentine note to my wife. It goes into the model, it generates a note. I make some corrections to it because it I don't know, got something wrong in that sweet note. And then for me, I've finished my use of that AI tool. But there's a feedback loop, and it can take my corrections to that output and feed it back to improve the model so it's more accurate. And that feedback loop becomes relevant as we think about controlling risks, particularly in the clinical environment. Specifically, I'll note here real quickly that the feedback loop for FDA-regulated devices is going to be paused and happen on a generative basis, while that feedback loop for many other technologies is continuous. So that is maybe a picture that you can have in your mind as we move through some of these risks. So what are our primary concerns when we're dealing with artificial intelligence? What keeps us up at night, or should keep us up at night? First of all is accuracy. Is it going to get the question right? Is it going to get the answer right? The second is bias. Bias is it giving a variant on the answer inappropriately to the input data? Discrimination is a derivative of bias and reflects generally by the prior discriminatory activities of society that gets pulled into data sets. Issues like access to care in a historic data set can establish bias and perpetuate discrimination on a go-forward basis. So that's why it becomes relevant to our understanding. Another concern is transparency, understanding enough of how the AI works, understanding the data set that went into training that AI, and its output range for accuracy. Data transparency, right? We're talking about data. You always have to pay attention, particularly in the space of health information, so PHI. You have to pay attention to who has access to the data and what capacity and what can they do with it. It certainly presents, AI also presents a challenge in security, whether it's another connection point to our network or it's the ability of AI to impersonate an individual and assist cybercriminals in running our current security systems. Finally, particularly in the clinical space, we've got this maintenance of professional discretion. Or if you're in-house counsel and thinking about this, the question is the licensed professional attorney making the decision, or is AI? So in all cases, we must ensure that if we are relying on a licensed profession, that we have the licensed professional appropriately engaged in conversation. So why do we care? There are going to be two big themes here. One is data. Data has value, and there's a saying that data is the new oil, right? Data is, as noted by the FTC, data is the critical raw material that drives innovation in technology and business. And like oil, it must be collected at a massive scale, then refined in order to be used and useful. That idea has been magnified with artificial intelligence, because as you saw in the picture of how AI is organized, data is the raw input into an AI tool. You feed in a lot of data so that it can start making accurate predictions. And that quest for all that information means that we need new massive data sets. The more data that's fed into artificial intelligence, the more accurate its output. So all of that hunger for data has lifted the value of data in the marketplace. Also noted that data, much like oil in its raw form, doesn't have a lot of value, but also presents a lot of risk to society. And we're seeing that analogy play out in the data privacy space as well. As vast amounts of data are compiled, then the question is, what information about an individual can be extracted from those large data sets, and raises concerns. So I'm going to, in this world of why do we care, we're going to talk about two executive orders. The first one from the Trump administration in 2019. In that 2019 Trump administration executive order on AI, a couple of things were highlighted, right? The federal government's role was to facilitate AI R&D. Second, the federal government has a role in ensuring that the American people can trust the development and deployment of AI technologies. Third, it's imperative that the federal government ensure that workforces are training on the use of AI and the impact of AI on their occupations. Fourth, that the federal government has an interest in protecting U.S. companies' development of AI technologies from exploitation internationally and ensuring that the U.S.-based intellectual property rights are maintained. Fifth, the U.S. should be first in the world in leading AI, and we should really control the market. Finally, the Trump executive order noted that American technology, economic, and national security should also balance civil liberties, privacy, and American values, and enhancing the international and industry collaboration with foreign partners, right? So the U.S. should be first, and as we develop a marketplace for AI, we need to also keep it in context of our national values. And we have the Biden order. Very similar things coming 4 years later. We see highlights on safety and security, privacy rights, equity and civil rights. Specifically in the Biden order, they noted we need to take care of patients, but we've got to promote innovation, we've got to take an American leadership, and we have to be responsible and effective use of AI. My point by sharing these two executive orders is, despite the fact that the Trump administration has already indicated it intends to withdraw the Biden executive order, both executive orders on a high level summarize the issue similarly. So we're not likely going to see massive change based on those two executive orders. Those executive orders themselves, though, is not the end of it, because we have regulations that have now been implemented based on either or both of those executive orders, including most recently, ONC issued HTI-1, and in HTI-1, we got the first real taste of how HHS is going to address artificial intelligence and the need for transparency. Specifically, HTI-1, for those who don't read regulations for fun, addresses the obligations of EHR vendors when they include artificial intelligence-driven decision support functions within their software. So your Epic, your Cerner, your Meditech, when AI supports the decisions, or when decision support is powered by AI, there's a set of regulations that explain what transparency level is required of those vendors. The other thing that we saw in HTI-1 is ONC start to articulate an analysis for governance or on risk in AI technology. So that was ONC. Here I want to highlight, in addition to logos from a half dozen or more federal agencies in April of 2024, we're seeing a lot of broad statements by the federal government, all pursuing a couple of common themes. The first being that the development of AI needs to ensure that it does not carry forward discrimination and bias, right? That, as was noted by the OCR, Section 1557 of the Affordable Care Act, as you may be aware, prevents AI-powered algorithms from contributing to bias and discrimination in healthcare, right? That's the OCR's position. Next, we've got the ONC, right? And the ONC's rule, they're talking about transparency, so not bias, but they're focusing on, will healthcare providers understand and have sufficient access to understanding how AI tools work so that they can perform a risk analysis. Finally, the FDA issued its guidance and then indicated that AI-powered clinical decision support tools should be subject to the FDA's regulation. Now, HHS also issued this graphic, which helps you take those words I just gave you and break it into columns, right? So OCR is dealing with bias and discrimination. FDA is really focusing on the efficacy of the AI-powered tool. And the ONC is focused on transparency of the information driving that clinical support, clinical decision support software. The FBI, DOJ, EEOC, and FTC have similarly issued joint statements addressing the risks of discrimination in AI and other automated tools. And across the commentary in all of those regs, there are comments and concerns related to how AI tools that have been trained on historic data can amplify historic discrimination practices, so that as you invest in AI tools, part of your inquiry should be, how is this tool trained? As the tool was trained, will it perpetuate historic discrimination and biases? That applies both in the kind of civil rights space as well as misunderstandings in historic medicine, right? We have new advances in understanding medicine, and if our data set reflects historic understandings and not state of the art, then we may be pulling forward bad information on even in the clinical space. So why do we care? We care because, one, we have an obligation to maintain privacy of our data. Second, our organizations, data is an asset. It has value. So we care because we want to protect the value of our organization. Third, we care because the tools that we use, particularly in the clinical environment, they need to be safe, they need to be effective, and they need to be non-discriminatory. We care because AI is a new type of technology, and it's going to require our workforce to recalibrate, that they may get a question mark or an underline instead of the number 2, referring back to my flashcard example. Finally, we care because the legal and regulatory environment is developing. It is shifting, it is changing, and it's not fixed yet. So a lot is happening in this space. So AI governance, right? That's why we care. How are we going to structure this? How do we take our organization from these risks and start building some structure and getting the right people around the dinner table to make the right decisions? So remember, governance is a process used to make informed decisions. And in the case of artificial intelligence, it's making informed decisions about how our organization will acquire, implement, and use and monitor ongoing use of AI. AI governance is driven by a policy, right? An AI governance policy memorializes what those workflows are. And the way that we're getting there is we're going to look at the NIST standard for artificial intelligence, right? NIST, National Institutes of Standards and Technology, driven by both the Trump and the Biden administration orders, developed a framework for analyzing and quantifying risks for organizations, broad industry, right? Not just healthcare, all industries. So then we take that NIST standard and we look at our organization's existing structures and start to apply that standard and then figure out what the gaps are. So the NIST framework identified step 1, build a governance process. That governance process has policies, procedures, and practices. And in healthcare, we already have a ton of those. So we're not working from a whiteboard. It's best and most effective to use what we already have and understand how those align to the standard and how we plug those gaps. From my perspective, I tell clients, we want to have a governance process that's workable and improves on where you are tomorrow from today. I would much rather have an imperfect governance process that's implemented than the perfect governance process that can't be implemented or is not broadly adopted. So my focus when I look at governance for healthcare is, how do we take existing structures and tweak them to improve our position, reduce risk? So we take our current policies, procedures, we start to understand those within the specific use case of an AI tool. And with AI, you always want to look at the use case. We're gonna map the risks. We're gonna understand what those risks are in the context of our use of that tool. We're gonna figure out how to measure those. And we're gonna do that both on a at time of acquisition and over time basis. So not just a single instance, but on a continued basis. As well as we measure those risks, we're going to figure out, are there strategies to help us manage or reduce those risks? Risk framing That's the composite measure of an event's probability and the magnitude of its harm. A lot of the publications that are out there that are talking about risk framing and AI will say that one of the things that you have to do is you have to build a barrier between a harm to a human and the deployment of AI. Well, in the space of healthcare, that's just not feasible. Everything that we do has a potential to harm people, so we have to do it smartly and ensure that we've got good processes around risk framing. So if you're looking at the NIST framework itself, you'll see there's some commentary about the risk to humans, and you just have to dilute that a little bit because it's just not manageable in healthcare. But one of the key ways that we mitigate risk is that we look at the role of the human and the way the human interacts between the patient and the AI tool. So that risk standard breaks down into safe, secure, resilient, explainable, interpretable, privacy, fairness without bias, accountability or transparency. And this is done at the time of acquisition and over time. That's the NIST framework summarized. And those concepts are what were articulated as necessary for the American people to trust the development and deployment of AI, harkening back to both the Trump and the Biden executive orders. This slide, we've got additional detail around each of those factors. Note specifically that valid and reliable gets broken down into valid, reliable, accuracy, and robust. One of the questions is what kind of inputs would break that AI tool, give it resulting in hallucinations or errors on the output. So as you're analyzing a tool, understanding the spectrum of inputs that are acceptable to that tool. Some of the large language models have a very broad input model. Others are more narrow. So part of the challenge in AI tools is ensuring, as you validate a tool, is ensuring that your spectrum of inputs is acceptable. That spectrum of inputs may be clinical information, or it could be language, right? We're buying an AI tool and we've analyzed it in English and it's totally fine, but is our patient population also going to use Spanish or Navajo or some other language in front of that device that we now need to address and validate? So valid, reliable, safe, secure, and resilient. Secure and resilient is in great part probably managed already through your data privacy and security process, but it's worth noting. Accountability and transparency is really a focus in the clinical space because providers need confidence in the tools that they're using. Point one. Point two, because AI is a different type of technology, we need to ensure that clinicians are continually suspect of the results so that they are not relying on the output of an AI tool. We have a long history with technology of always thinking of computers as being correct, right? 1 + 1 = 2. However, AI is not that technology. It's a different type of technology and requires recalibration. So as we start to digest these risks to our health system and try to understand what it means, who should be at that table? And generally what we're seeing on who is at the table, of course, we see security, privacy. Those are kind of traditional IT factors. Diversity and inclusion becomes relevant because we are guarding for both bias and discrimination. The amount of data consumed by AI becomes astronomical, so data management also often gets involved to understand the data that's flowing in and out of this AI tool. Point one. Point two, data management also becomes really important when we start to think about what information are we gathering or analyzing about how we use AI and who should hold that data and who should have access to the data about how we use our technology. Clinical leadership, you've got to have their buy-in if they're going to use this new tool. Finance, human resources, because we've got ADA and 1557 compliance concerns there. Compliance, legal, and ethics. That's generally who's sitting around as we start to put together an AI governance. So what's this AI governance look like? Going back to my picture pages, here we have it. On the right side is common working groups, governance structures that exist in health systems. Legal compliance, med staff, ethics, peer review, research, IP management. All those are common working groups within health systems. The bigger box there, IT review, security review, disaster recovery, that's kind of your CIO office operations, maybe a connection with the CISO, and then you've got privacy and data management. Those are all existing working groups. On the far left, I've listed the 7 factors for a NIST risk management, and you can see how some of those factors can just go directly across over to our existing working groups. Now these boxes in the middle, the AI governance, right? So over the top, someone's got to be responsible for AI governance. And generally that is a smaller committee, including the CIO. Generally, you also have some version of clinical leadership there. Some version of risk or compliance is on that top box committee. That top box committee has ownership of a couple of factors. One, they own the workflow of how do we analyze AI. Second, they own responsibility for educating the workforce, not just clinical leadership, but the entire workforce on the risks of AI. And those risks range from the AI tool that's used at patient scheduling to the AI tool that is ambient listening in physicians' offices, as well as training all the workforce on how AI can be used by bad actors to compromise your privacy and security. So AI Governance Committee owns the education of this new technology. Then we've got to move at the pace of medicine, which is quickly. So we've got separate towers for clinical, finance, and individual. Once a use case is raised to the AI Governance Committee for a proposed technology, it gets routed to the appropriate subcommittee to evaluate that use case against the NIST standard from a total perspective. That use case then goes off to the various working groups for their contribution, right? That use case may be an IT review, there may be a med staff review, there may be an ethics review. I also want to call out here peer review because it's the first time I'm talking about it. So say what we're doing is we are using we're evaluating the ambient listening technology that's going to listen to our patient encounter, and then at the end of the encounter provide to the provider a draft physician note. The physician can then edit that note and finalize that note. We may have many concerns about the accuracy of that tool, but one of the things that we can do is we can charge the peer review committee with gathering data related to physician use and ensuring that physician use of that tool is appropriate and effective. And that use of the peer review committee for providing oversight of how our medical staff is using the technology and is it being used correctly becomes important as we think about the data that we're gathering about its use. So the consideration of who asks for data about our use of that technology and how do we appropriately control that data flow. So that's why peer review is listed here. So that is at a high level how we might start to structure a governance model for AI governance. Now, as I said, it is best to have a governance process that you can implement and is an improvement over your existing structures. So not all of these boxes may be involved. This was drawn up for an academic medical center, but you may not have all those boxes and you may be a smaller organization. So the goal here is to connect each of those risk factors from the NIST framework to appropriate working groups within your organization so that we are providing a more informed and organized decision. Noting you've been using AI likely for 10 years or more, and this is not new. What you're doing is memorializing how you get the appropriate stakeholders to the table to make an informed decision. So putting all this together, right? We're going to establish that AI working group, right? That overarching body. And what are they going to do? They're going to own the AI review process that includes the technology, the human, and the data that we gather about how our humans use that technology. that human component of who is using or how is the human using that technology. We're going to go back right here, right? We have this AI governance committee. They approve that use case of the ambient listening technology. And so go forth. We're going to have our peer review committee do an inquiry and follow our statistics on maybe time from the publishing of the note to completion of the note. And then what do we do at that point for purposes of managing that workforce? The peer review committee can feed back to, say, chief of surgery, if we're talking about a tool used for surgery notes. And at that point, the chief of surgery then is in his management role of advising physicians on their appropriate or inappropriate use, right? So we're going to use our existing structures, not building a new body. So who owns the AI review process? It's not a single individual, but we're managing the technology, the humans, and the data. We really want to identify and leverage those existing working groups. That makes this a reasonable hill to climb for a health system. Also, that AI governance committee is going to develop an organizational education plan so that everyone understands, whether you're doing scheduling or whether you're a physician, everyone understands how AI works and can reacclimate themselves to what they need to be doing as they use an AI tool. The examples range from discrimination in scheduling appointments to hallucinations on diagnosing skin cancer. So it's a broad range of impact for organizations, and across the board, we need training. Once that AI use case is presented to the governance committee and being analyzed, it's going to look at it on a use case basis. It's going to identify and quantify the risks. It's going to implement mitigating strategies to reduce those risks. Risks that cannot fully be eliminated are monitored on a go-forward basis. And they may need to create rules around that go-forward use case to ensure that we stay within acceptable parameters on risk. In addition to that kind of time of acquisition of AI analysis, we also monitor these items on a go-forward basis because this is not a single transaction. Remember that feedback loop is constantly reshaping the AI tool. So we need to monitor that AI tool, and someone's going to do that. Generally, what we find is that the monitoring of the AI tool is best handled by those who are the closest to that tool. Concept of subsidiarity, right? Put the person closest to the tool in the position of monitoring it and being responsible for it. So risk mitigation, going to move rather quickly through these. I've talked some already about these risks. So transparency, as you think about transparency in the tool, you want to understand who is the AI developer, right? Are they the ones that are using it, or did they develop the AI tool for the market? If they developed it for the market and they're not the ones using it, what interest did they have in developing the tool? Right? Because as an AI developer, I can certainly shape my outcomes by my training data, by the way I built my model. Did that developer of the AI tool have any vested interest in the outcome? Was that AI tool funded by the training data provided by, say, a pharmaceutical company? If so, does that AI tool have any kind of bias in favor of that pharmaceutical company's products? Additionally, what information is the vendor providing about the training of the data, right? This is the point that you're really going to start to push the vendor for transparency. If they don't want to tell you about the tool, then you're going to have a hard time, one, getting your clinical staff to rely on the tool, but second, clearing your own requirements of removing bias and accuracy concerns with the tool. Right now, the greatest mitigating tactic in AI is human supervision, right? And there's really 4 levels when you move across the spectrum. The most common is human in the loop, right? This is where, like clinical decision support, we are supporting a human reaching the right conclusion. So that's human in the loop. Human consent, right? That's where it's prompted for a human just to say, yep, okay, you're clicking okay. Human intercept, that is where the human has to take an affirmative act. Otherwise, the AI will act on its own, but there's the opportunity for a human to interrupt the workflow. And finally, there's fully autonomous, right? The chat bot on your website that's walking a patient through symptom checker, fully autonomous AI. That one is a lot harder when you start to think about how do we monitor for bad outcomes or hallucinations? How do we make sure that that tool is providing good feedback? It's very easy to think about it in the human in the loop scenario where your clinician may say, wait a minute, that result isn't right. But when you don't have your clinician between the AI tool and the public, it's a much higher risk scenario. So this is the same picture you saw earlier today, but we've added just a few things here, right? Over here on the bottom right on the feedback loop, we just talked about supervision, right? What is the role of the human in supervising that output before there's an action, right? What is the role of the human before AI action is taken? And what is the relationship between the human and that AI tool, right? Does the human feel that they're just taking action as directed by the AI tool, or do they have the appropriate level of suspicion of the AI tool? That becomes really important as you think about educating your workforce and who gets to use AI. Are they empowered to tell it no? So mitigating the risk, first and foremost, be curious. Don't rely on the black box to be right. Make sure that the vendor or whoever created the AI is willing to spend the time to explain how it works. Right now, best practice is to preserve ultimate clinical judgment to a practitioner. We don't buy medical malpractice insurance for AI. That risk still sits with the practitioner, so if they're using the tool, they are accountable. And keeping them in the loop and engaged is very important. Finally, what is the feedback loop? How do we identify, report, and act on those errors and hallucinations? And that becomes relevant and pops up here as we start to move through the contracting provisions as well. Understanding bias. So as I mentioned, bias is the unequal performance among individuals across groups or unequal predictions for similar individuals belonging to specific groups on a comparative group. So the best examples of bias is as we start to look at data that was developed based on treatment models, historic treatment models, not all social economic groups have the same access to care. So we can start to see bias develop when we have data that has the impact of access to care. So when you're acquiring an AI tool, one of the analyses that you may do is evaluating how the vendor controlled the training data for those historic biases in their input data. That is called model risk. Model risk is when model risk. The other issue is algorithmic risk. That's the data used to, had those backwards. Algorithmic risk is when the input data reflects historics wrong, and that can also result in discriminatory outputs. Algorithmic or model risk is, on the other hand, when the model itself has influenced or a negative attribute that creates inappropriate outcomes. A couple quotes from the ONC as they highlighted their concerns on bias and discrimination. And these kind of comments have covered both the Trump administration as well as the Biden administration. These quotes just happen to be out of the more recent rulemaking. But across the board, regulators have a broad concern that AI is not just neutral, but could amplify historic discriminations. So as we pull into those training models, it's really an important focus of regulators right now, and they need to understand that black box. So with all this process built around how we acquired AI, and we talked about the regulatory drivers on it, the question is, what are the litigation risks? What's driving our concern? First, fraud and abuse, right? In the fraud and abuse space, we're seeing AI tools develop that help you draft your physician notes. Those tools can also assist in coding and billing. One of the concerns is as we develop those tools in the space of physician notes and coding and billing, are we going to run afoul of fraud and abuse laws? Consideration has to be given on what training data and what range of outputs is permissible by that tool. We certainly need to pay attention to the accuracy of the physician notes and tracking what is being pro-offered by the AI tool as the physician notes to be accurate with the physician encounter. Said alternatively, is the information in the pro-offered physician note accurate, or did the AI model sway that because it's been trained to seek higher reimbursement levels? In the anti-kickback space, we certainly need to pay attention to how was that AI tool funded, what's driving that. There's certain concern for third-party developers that were funded and selling AI under market value, that would constitute anti-kickback. Unauthorized practice of medicine. One of the concerns out there is that the provision of AI tool in the clinical space could constitute the practice of medicine. None of the states really addressed this yet. It's a theoretical concern, but certainly consideration must be given to our physicians inappropriately deferring to AI technology. That impacts the medical malpractice analysis as well. There is history on discrimination in employment claims, particularly where AI technology shows discrimination, if we're using AI technology to scan applicants, do resumes, et cetera. There's certain risks for that, and those have been documented well through to today, including at the EEOC level, where the EEOC has expressed concern that AI technology may have historic discriminatory factors that are pulled forward. Data privacy and security considerations. There is so much data involved with this. You've got to keep your privacy officer engaged in the process, because the agreements that you're acquiring the technology through can have scope creep. So not always is AI functional added through a procurement agreement, but sometimes that AI tool is rolled in as an update or an upgrade, and that can change the scope of the services provided by the vendor, thus them expanding the scope of their use of your data because it's still in provision of services to you. So you end up with a vendor scope creep on your data access. The FTC recently issued some guidance stating that it is not permissible to prospectively modify privacy terms, that if the terms of privacy on a tool or a website are modified, they can only apply prospectively and not to historic data that you have. That's still being sorted out a bit, but we've got to pay attention to the FTC Act as they've started to flex their muscle on what's fraudulent business practices. Additional data considerations, right? We've got several classes of special data, genetic data, mental health data, substance use disorder. All these special classes of data have different treatment. And if the scope of the AI tool, the data that it's using, expands the scope of the vendor, we can start to run into challenges on where our original privacy controls at the time of acquisition of the tool sufficient, given that the AI tool is now grabbing broader data, right? Previously, there may have been no reason for the vendor to have access to mental health data, but because they now implemented an AI tool, that AI tool may do a broader data grab as it's providing predictions for, say, diagnosis, and will we have the appropriate controls on our data flows to that vendor. So in short, privacy risk mitigation means you've got to understand that the tool can change even mid-contract. And that is a real challenge because most organizations are relying on the procurement process for managing data privacy. So that AI governance process, having a kickoff to privacy, is helpful because we may just have a use case change as opposed to a new contract. And that use case change could prompt privacy to reevaluate compliance concerns. Security. This is really going to pop up in how you train your workforce to understand that AI is very good and our phishing attacks are much more sophisticated now than they were previously. So contracting for solutions, I'm going to move through this and then get into questions. Key concepts in contracting, right? You want to control for the introduction of or modification of AI and technology. If I don't have a procurement agreement, how am I going to deal with it? So rather than having to worry about that, I'm going to force my vendors to require written authorization before they introduce AI technology. I'm going to address that feedback loop. I want the vendor not only to permissibly accept my feedback, I want them to take that feedback and have an obligation to make a correction based on that feedback I give them. And I want to report back on how they incorporated my feedback to improve their product so I can close out any risk I have associated with that. Finally, ownership and control. AI is a really exciting place. Everyone wants some ownership or control in the training data, in the model, in the output. These are certainly complex questions that you'll need to work through with your vendor. Almost always the vendors are going to say they can't give you any ownership or in any of that. I'm going to counter that and say that you always own your data and they only had a limited right to use it during the term of your agreement with them. But certainly issues that need to be flushed out with your vendor and particularly in your procurement process. Ownership of the output. There's been a little bit of a case law on this in the copyright space. In the vast world of health IT, the majority of outputs that we're talking about are draft physician notes and draft findings that are then adopted by a physician and edited. So ownership becomes a little less relevant in that space. But if you're generating videos or something, it can be more of a concern. So that governance process, making informed decisions, what are we really talking about, right? We've talked about what is AI. We've talked about why we care. We've given you an AI governance structure. This all relates to mitigating our risk, right? Primary risk being bias, and how do we control for bias? How do we start to draw the lines between our source data and the outcomes that we want? A little bit of litigation risk and data privacy considerations in contracting. And with that, I want to pause because, Chris, I believe we had a couple questions that came in.
Yeah, Michael, what a great presentation. And I really do appreciate all the information that you provided to our attendees today. I want to remind our attendees that if you have a question, type it into the Q&A box. And I have a question here. Who is responsible when a patient is hurt by AI?
It's a great question, right? And I've given this presentation a number of times, and then that's always one of the first questions, right? The medical staff that make that decision, it's no different. AI is just a tool. It's no different than a scalpel. So the practitioner is ultimately responsible for this. And that's why it's really important to ensure that they understand that this is a different type of technology. It's not the calculator that's 1 + 1 = 2. It can give you different answers, and they need to be appropriately suspect of that tool, because right now there's no other insurance that's going to cover it. It is the clinician that's responsible for that, and it falls within the standard of care. Did they make the appropriate decision with respect to that patient?
Okay, I have another question here. Who typically leads the development of AI governance?
A good one. It's a little bit of a mixed bag, depending on how health systems are structured. I have seen some where the clinicians take the lead because clinical leadership is really focused on getting these tools into the clinical environment. How do we serve our patient base? So in some instances, you'll have strong clinical leadership that wants to drive this. It falls off a little bit as they start to look at deploying AI in the employment process. So they may drive the organization to building that governance process. And then you may recall that we had that clinical tower within the clinical space. Their role may, once they get that governance process built, focus strictly on the clinical space, letting those other towers be managed appropriately. In other instances, it'll be the CIO because this is a huge technology load on their organization. So between clinical leadership and CIO is most often where I've seen it. Um, a couple examples where legal and compliance came in. They looked at all the risk mitigation and exposure of the organization, and they decided that that process maybe existed informally, and because it existed informally, they didn't have the internal buy-in to really force the memorialization into an official process. So legal or compliance came in and helped get them there. And with that formalization, it also drove greater efficiencies. So those are the three primary leaders of the governance process.
Okay, Michael, it was a good question. It came in from Tiffany. How would you go about setting up an AI governance structure for a small, medium-sized hospital that is yet integrated AI into their organization? Would the structure be similar to the one you discussed?
Yeah, so scaling this down, right? And that's it's something I'm really passionate about is how do you take your existing structure and start to adopt it, right? So likely as a smaller hospital, you likely have a security review process for anything that's plugging into the wall or connected to your network. You also have a privacy considerations, right? The peer review piece you may not have, right? So how do we take your use today and engage somebody else? All right, sorry, how do we take your use today and make that work for AI? What we're going to do is take your existing structures and improve on where you are. So if all you have is security and privacy today, and your biggest risk is understanding the bias of this technology, we're going to make sure that as you get that technology implemented, that AI solution, that you're not out on the cutting edge, that you're kind of following on the heels. There are organizations like CHI, the Collaborative for Health Information, the Collaborative for Healthcare Artificial Intelligence, chai.org. They're building a grading scale for AI technology. So some of this burden of understanding the technology and the bias would be removed from you, and you can rely on their certification of vendors. That's a large work effort. Epic also has a grading tool for AI solutions, so you can understand model drift within the Epic's tool. But if you can just start to catalog your AI and also understand enough of when you are in over your head. If you're a 25-bed hospital, a critical access hospital, and a vendor approaches you and wants to co-develop an AI tool, you might be in over your head with that arrangement, because you do need to have some pretty deep understanding of data analytics and how AI works before you can really be a strong partner. So if I were a smaller hospital, I'd look at privacy, security, risk mitigation, and absolutely make sure that my clinicians that want to use that AI tool understand the risks associated with it. The thing that keeps me up at night is the RVU-based physician compensation, when we give them a bunch of tools to move really fast, and then we start to collect data that shows that they're moving really, really fast, faster than they could really actually do the work. That's a really bad scenario, right? And AI presents the tools to work really fast. We also have CIOs that collect data on how quickly are my physicians, how much have I improved my physician's workflow by giving them these tools, so that measurement data gets to be really concerning. So are we collecting that through peer review, or how are we collecting that? So it is really important to understand your place and what data you're collecting from a risk perspective. Is what data are we collecting about how we're using these tools can be a reason to lose a little sleep. So focus in on, is the technology safe and effective? Do I understand how it works? And is it safe and secure from a technology space? Finally, give consideration to any data that you're gathering about how you use the technology, and make sure that if you're gathering it, you're doing it intentionally, and that gathering that data doesn't expose you to greater risk.
Okay, Michael, you received a compliment here in the chat box that says that you are truly on the forefront of implementation and developing governance policies. And they also say early implementation has shown to be a great return on investment. Now I'm going to ask you a final question. I'm going to ask you a final question here. I think it's a good one. Is there reimbursement for AI?
Yeah, there is. The CMS has issued some reimbursement advantages for AI tools that's FDA regulated AI tools. There are also questions that relate to whether an AI tool can always be used as a standard of care, or does it require specific findings by the physician. And that's really important. That space is developing because there's always a concern for overutilization. Did the physician need to use that AI tool, or were the preliminary reads of that image fully sufficient? So that space is developing, but there's certainly some reimbursement out there for AI technology.
What a great webinar today. We really appreciate your expertise, Michael. We appreciate the attendee questions. Any final thoughts?
No, I really appreciate everyone's time and attention. It's really an interesting place, and certainly one that Washington's going to be focused on in the coming years. So, all of this will change certainly, but it's certainly advancing, providing a lot of opportunity for efficiency and improvement of patient care.
Thank you, Michael. And I'd like to remind the attendees that Michael has been kind enough to allow us to distribute his presentation today. We also recorded the event, and I will send a link to everyone who registered for today's webinar. Michael, thank you so much. We appreciate you coming to us from Indianapolis. And I'm going to go ahead and end the webinar now. Thank you, sir.
Thank you all.